Okay, so welcome to the first episode of the Autonomic Dudes. I'm Dr. Rob Wilson and my trusted colleague Kyle Shannon, APRN. Hi, Kyle.
Hey, Dr. Wilson, how are you?
Oh my gosh, so formal after all these years of knowing you for a decade. I am
All
Robin.
right, Rob. All
Please
right,
do.
Rob. He's always Rob.
Or Robbie. This is going to be, as you already get a sense, this is going to be very casual of us going back and forth. So we had this idea based upon a lot of feedback from patients over the years, and we're finally doing this podcast series of information for the patients, their support people, and hopefully their medical providers to give them tips and cues and help alongs about autonomic disorders like POTS and orthostatic diagnoses and sort of help alongs, right, Kyle?
Yeah, that's right. I think, we get reach outs all the time from different specialties, family practice. And Rob, you take care. I used to see a lot more different patients from out of state, but you see a lot of patients that are from other regions that may not have big medical centers that deal with autonomic disorders where patients kind of feel isolated. And so I think this provides some insights into what we do and how we can take care of patients. And it's interesting. I mean, Rob, it's what, 7 centers nationally, roughly, that are considered autonomic centers in the United States.
I mean, you're absolutely right. It's interesting. The nervous system is such a big driver of the body. There's only 7 autonomic centers before COVID. We'll get into this a little more. There was about 1 million people with POTS. There's globally, there's 70 million people with autonomic dysfunction or dysautonomia. That's the population of Germany, or if you take the population of California and Texas together. So these are not rare diagnoses. They're common, often not commonly thought enough about. Probably an issue of still not enough proper training in medical education. That's the reason why I'm very committed to education. So it's really getting people a little more, getting in that zone about thinking about it, some simple tools to help people get there. It is a big deal. And you're right, a lot of patients that come to us are national. I think in my practice now, 60% of patients are an air flight away, and they are about 6 to 8 hour car drive away, which means people are spending a lot of money, time, effort, physical energies patients don't have. And then when they go back home, as you're very eloquent about this, that it's a challenge with the whole pandemic influence where the entire United States is going virtual online, with email portals of patient care. It gets challenging if someone says, I can't breathe, I'm lightheaded, I'm dizzy, I'm woozy. It's hard to address it if someone's 500,000 miles away safely. And we need people to actually have resources home to know what's going on, and really try to empower people to say, hey, what can be done locally in our own backyard? My college always had a saying, find diamonds in your backyard.
Yeah, there's people out there that there's healthcare professionals all around that are willing to learn this stuff. It's just like you said, in medical education. I can't speak to the physician route, but in advanced practice nursing school and nurse practitioner school, physician assistants, we don't get much education touching on orthostatic disorders, especially POTS. I mean, we touch a little bit on orthostatic hypotension, but POTS in and of itself. I mean, I maybe saw some people in the hospital setting that had it as a list, a problem list. And I always kind of remember it being a naive young nurse saying to myself, what in the world is POTS? And then, I get paired up with you, Rob. I mean, I know we didn't really introduce ourselves too much here. I mean, Rob and I have been working with one another since going back to 2014 when
Da-da-da.
I was a bedside RN, and he was covering inpatient hospital, and he was always the neurologist that would answer the phone or pick up the page, and I gravitated to him just because he was kind-hearted and always willing to help. And I think that that translates also over. He's not just that way with other healthcare people. He's that way with his patients, and I think that's why people gravitate to you. So yeah, I mean, we can definitely jump in, but I really enjoy working with you and working with this patient population. We have a blast every day that we're together. So, I
Yeah.
mean, I hope that we can, this podcast will kind of last and that we're able to really make an impact for not only healthcare individuals, but also for patients and their families. I think that's another topic here. Families don't always understand what the patients are going through. So I'm hoping that we can kind of really jump in and give some insights.
Yeah, I think it's absolutely brilliant. Thanks for the kind words. And you were never a naive nurse. You're always outstanding in many bedsides, many emergencies, and always had good spirit, good fun. But I think one of the issues is, well, let's start. We're going to focus on POTS a little for the POTS initially for a little break-in because it's so common. But I think a big aspect is in medicine and in neurology, we talk about neurophobia. And probably one of the issues is that people in healthcare are very afraid of neurology or clinical neuroscience. It probably starts out from the first 2 years of medical school, where it seems so intimidating how to learn the neurosciences. Even I didn't like neuroscience my first 2 years. I was gonna get OB-GYN. Then my neurology experience in my clinical years, third year, I fell in love with it. You could hear a story, put it together. You just fell in love with it, and it became like all these treatments and possibilities. This is the 90s, and I changed into this. So I think a lot of times people still clinically feel very phobic or afraid of dizziness, fatigue. Is it something or nothing? Is it nothing mean in the sense you're am I missing something life threatening or how to navigate the patient in that regard? So we're always combating neurophobia in healthcare. And people don't feel comfortable with it. So it leads to patients sometimes being shuffled around or not knowing what to do. And it's not judgment of anybody. It really is how the system is. And about 20% of medical schools don't have what we call neurology clerkship experience, where people really spend focused time on neurology to learn how to maybe get in that zone to handle it. But let's talk about POTS a little, because
Yeah.
when I was in med school, POTS was, and many people Google it. I think the internet's changed a little because it is about postural orthostatic tachycardia syndrome. But my licensure exam, it was always tied into tuberculosis of the spine.
Oh,
So I
how long ago were you in medical school? My goodness.
Oh, those days we didn't have the internet. There was no Facebook, Lassie. But so occasionally you'll see that coming in. Someone will say to you, "There's a patient in the hospital with POTS, but they have no TB on their chest X-ray." And I go, "Oh my gosh, wrong internet search, as in someone's using one of the older internets, not the newer ones." But so
That's POTS with two T's. That's
yes, yeah,
it's
wrong Google,
that's
wrong
T
AI
squared.
search
That's
engine.
POTS with the T squared.
Yes, yes. So POTS, postural orthostatic tachycardia syndrome. I don't know if you want to just discuss it a little.
Yeah, yeah. So I think clinically, right? So postural orthostatic tachycardia syndrome, the name is pretty kind of redundant when you think about it. Postural and orthostatic are relatively the same exact meaning, in my opinion. But it was termed this basically individuals who stand up and their heart rate just starts to accelerate. When you think about normal physiology, an individual stands up, we all naturally are going to have a slight increase in the heart rate, 10, maybe 15 beats, but it's transient. It's a natural response as blood kind of drops out of the core into the legs, and the body senses the drop, and it just needs to work it back up. And this is a very quick process. This is part of things that we don't have to think about. It just happens. But in individuals who have POTS, they stand up and that blood drops, and the body has a sympathetic overshoot where the heart rate accelerates by 30 or more beats, and it's not transient. It shoots up, it stays up, and it might even continue to climb. And it's kind of the body's reacting to the fact that it doesn't feel like it's getting the blood flow that it needs up to the head. They get dizzy, they get lightheaded, they feel faint. They often feel shaky, they feel sweaty. It's almost,
Yep.
this is, Rob, why I think a lot of our patients, before they get to the right individual, they often get termed as having panic attacks, anxious, because what does that sound like when your heart rate goes high, you're breathing heavy, you're sweating, and you feel shaky, and you can't focus because your pupils get big, you feel light sensitive.
Adrenaline. It's
Yeah, it's an
adrenaline.
adrenaline rush, but you're getting it by standing up. It makes sense if you're on the football field or you're running from a bear. It feels right in those circumstances. But when you're just standing up to exit your bed or get out of the car to go into the grocery store, it's a very uncomfortable situation.
And that's, you just nailed it correctly. And adrenaline is such a confusing topic because in our culture we market it as adrenaline junkie, or adrenaline's a good thing that happens. It's meant to be a momentary experience, not sustained. And I think, I mean, you said it so well about how the body responds to do this. And it can be confusing because people will spike their heart rate, and even as conditioned, they will raise their blood pressure as an overcompensatory. And we'll get to the tilt table a little, but this syndrome, it's so common now. 1 million people before COVID, and we know that there's been 100 million people who've been COVID positive officially, and a good percentage of people who've not recovered from COVID now have POTS. It's like 1 in 4, and there's research being done with this, and we published data with this. So it's millions of people have something in that post-COVID long hauler autonomic physiology, and that's a whole different podcast we'll do probably.
Yeah.
It's fascinating. The syndrome's sort of destined for confusion because the original people discovered with this were the Civil War veterans who went back, they couldn't return to function, they couldn't return to their farm duties or their factory duties. They felt everything you said, lightheaded, they couldn't stand. And the treatments were loose clothing because they felt such weird sensations in their body, prolonged bed rest, which we know now is the worst thing you can do. And it was like what men, those syndromes mainly women, so which probably speaks of more inflammatory state, why it's more women. We know nothing about the men who got the POTS from the Civil War veterans. And then over the years, other odd terms we would use, like the Grinch's heart, like the heart was too small. But the hearts
Yep.
are actually fine. The hearts are actually compensating just well as a response. So it's a syndrome's destined to have had historical confusion. So, the tilt table, we'll get patients who come to us, even nationally, we'll actually make them repeat their tilt table, or we need to get a tilt table. Sometimes I repeat the tilt table because they give it a medication during a tilt table and almost sort of interferes with the vital drama of what you need to see this evidence.
Well, I think the tilt plays right. The tilt plays a vital role in several areas. So first, diagnostically speaking, obviously, if you don't have the ability to have a tilt table test, good bedside orthostatic vital signs can
Yes.
also
Yes.
help. So having the patient lay down for an extended period of time, 5 minutes, taking their heart rate, blood pressure after they've been laying down, stand them up, see if there's a change. And again, POTS is again the heart rate going up by 30 or more and staying up. And you don't want to see a drop in the blood pressure typically with POTS. I think that's where it can get confusing. I think we see a lot of patients who come through our doors who may actually have orthostatic hypotension, and their heart rate's accelerating to compensate, right? So traditionally, POTS, you'll see only the heart rate go up by 30 or more and stay up. I don't know about you, but I often know generally speaking, prior to the tilt, I have a pretty good idea. This patient probably has POTS. The reason I like to get the tilt is obviously confirmation, but it actually helps guide me from a treatment standpoint as
Mhm.
well, because I can see when this individual says, I'm dizzy, I'm lightheaded, or I'm getting tunnel vision. Is their blood pressure low during that time? Is it just that their heart rate is through the roof and they're not able to kind of perfuse appropriately? What do I need to go after when I'm trying to treat this person? And that's why I like the tilt.
Well,
And
yeah.
you're right. You alluded. Sorry, I'll let you jump in, but
Go,
I mean,
go.
you alluded to the fact that some outside facilities utilize medications like nitroglycerin, isoprel, different things to try to induce syncope, but in a POTS patient, that's often not helpful. I'm not worried about that aspect for them. We often do what are passive tilt table tests where we don't use medication.
I,
Can you speak a little bit more? I mean, this to why they outside facilities use nitro or isoprel?
I think they're trying to see if they can provoke a fainting event. A lot of times the old-fashioned idea is someone should faint or see how people's vitals are. It leads to a lot of false positive results. I mean, you're a tall, lean man. I could probably give that to you and make you faint. And the problem with that, I find, is that when you do a tilt table, you really want to follow someone's vitals through it, how they're responding, the blood pressure and heart rate, and then you actually will give people a medication, and you might then just really alter the data and then lose all your vital data you're seeing. Because you'll see a tilt table, you'll see someone's blood pressure and heart rate change and heart rate increasing. And then sometimes you'll see in someone who has POTS, suddenly, as their high sympathetic adrenaline response, the blood pressure heart rate's climbing, you'll see these moments suddenly where just our own body response is trying to have this parasympathetic vagal rescue where the blood pressure and heart rate drop down on its own to rescue them from the
Mm.
sympathetic state. If you give them medicine at that time, just by chance, you're missing this opportunity to understand someone's pathophysiology, their physiology of what's going on. That's why one of the reasons why I like watching a tilt table, because this might be help me give me an understanding how someone should be treated.
Yep.
There's a lot of reasons people do the medications. I think historically, one of the reasons why people like doing tilt tables to see, can you induce syncope and fainting? We don't want that. I think your statements are so important. This is why I adore you, is that it's like your knowledge and your pursuit of these patients is to understand how they're going through their day dynamically, the
Yep.
tilt table. The tilt table, I think, is helpful, like you said, is that these patients, something you said earlier, they're so knocked around through what they're going through healthcare sometimes, their families not being understood because the most dominant symptoms are fatigue, lightheadedness, brain fog, pain, that they're called vague symptoms. You can't necessarily pinpoint to a body symptom.
Yeah.
To have that objective data, this test is there, navigates their life, their healthcare systems that have that data. So the tilt table is the confirmatory diagnosis, and to sometimes study those numbers, you know dynamically what their biology or pathophysiology is going through. It really helps out greatly to have that number. People don't want to do a tilt table, but
Yeah.
it really encourage it. But you said something very insightful. I'm gonna get back to you. I think for the local providers, if you're in an appointment, even I will do this. Someone's sitting for 5 minutes, sitting blood pressure, heart rate, stand for 1 minute, blood pressure and heart rate, and 2, 3 minutes later, blood pressure and heart rate. If someone has something that's orthostatic, you're going to see something, either a rising heart rate happening or the blood pressure doing something.
Yeah.
That's going to be suggestive someone's going to have POTS orthostatic. Even if you have a few moments, you're going to find something.
Yeah.
Those
And I
patients.
think, too, going kind of also back to the tilt, you made a statement about syncope, and we're not the goal, when we're trying to figure out if you have POTS or orthostatic hypotension, is not to induce syncope. In fact, the data on POTS and syncope is that the majority, Rob, I think you've looked into this before. I think it's like 4 in 5 patients actually don't pass out
Yeah.
because
Yep.
they act, and this is a common misconception. A lot of people will say, well, I've never passed out, so I can't have POTS. It's like, actually, no, the majority of individuals
Yep.
feel the symptoms, right? They get that lightheaded, that dizzy, that weak, that diaphoretic, that the sweating. They feel crummy, so they can often prevent syncope because they sit down or lay down and their symptoms will subside with time. So
Yes.
it's a common misconception that we need people to pass out to have that diagnosis. That's not the purpose of the tilt.
You are absolutely right. People will have enough sense to um, 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 that will sit down, lay down to stop. That's why you're not, that number is correct. It's like 10, 15% will faint early in their diagnosis. People will then um, 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 change, compensate, they will do that. Racing heart rate, palpitations, or fainting will get you the ER, but brain fog, fatigue, dizziness, lightheadedness, and pain are the daily grind. It feels like having the flu and then drinking coffee every hour to get through the day.
Yeah. You
So,
always say the wired and tired
oh,
feeling.
the
I,
wired and
I
tired,
remember your old
right?
picture. It was like an ostrich that looked like it got electrocuted,
Someone
or like a
remembers what I
sloth that
say.
looked like it got
Someone remembers what it
electrocuted.
says. That's hysterical. So let's talk about some syndromes because I think is for people to know this, people have faint. The tilt table is helpful. Orthostatic. It's a common condition. Often we actually, building the point about anxiety, we published this data even that people who actually think patients report, I am anxious. Patients, when they self-report that they're anxious, who have POTS, still struggle sometimes to differentiate or get their adrenaline symptoms differentiate from anxiety, even amongst our healthcare system. So it's tricky to sort out those jitteriness, the adrenaline, racing heart rate. It's a challenge
Yeah.
sometimes.
I mean, to me, now granted, a lot of it is associated with posture change with POTS, right? Like, can POTS patients have sometimes when they're laying down at night and their heart starts racing and some odd things happen there? Yes, that's reported a lot. But generally speaking, that anxiety from POTS, that anxious feeling from POTS, that feeling where you're like, I don't know what's happening, I feel odd. Um, that's usually when after a posture change or you've been standing for a prolonged period of time, et cetera. You're right though, like this is, I think, where a lot of people that don't have a lot of experience with the diagnosis or managing it, even us, it can be hard to differentiate. And I find that patient health questionnaires in this scenario can be even more difficult because
Oh,
if the patient health questionnaires take into account physical symptoms and POTS patients have a lot of physical symptoms, so it can really muddy the waters. I often, if I have a patient who has confirmed POTS, it's not that you have to treat everything. You have to be holistic when you're treating these patients. You have to try to address both things. But yeah, what would you say, Rob? So when you have a patient come into your clinic and they don't have that confirmed diagnosis yet, and this is more so for like the healthcare professionals, what do you look at for mimics, right? What are some metabolic things that you're starting to think about, or additional workup before maybe you get this patient clean slate, never had a workup, never no testing done ever, and they come in with these symptoms. What are you thinking? Like, are you doing
yes.
blood work to look at like iron deficiency? Like,
Oh,
what do you like to look at to make sure this, like, let's say the individual, we have patients who don't have primary care physicians. And so what do you like to look at to make sure that you're not missing something?
I mean, great question. You do the same thing, but like typical things, most of these patients are young women or young women, and I'm gonna say young is anywhere from like 15 to 55 because I'm in the 50 range, so I'm gonna give myself that.
Yeah, you're young. You're young
Yeah,
at
yeah,
heart.
good answer, good answer. But like thyroid function, complete thyroid function, including T4, T3 uptake, you should include all those things. B12 is a big thing we find for a lot of our national patients. We find a lot of patients either as a response that from high sympathetic state with the POTS, you can't rest and digest in the high sympathetic state. A lot of low B12, it's in orthostatic guidelines. Anything below 450 with neurologic symptoms need to be treated. So that could be a factor that needs to be sorted out very carefully for patients is important. Is big idea. So those things, anemia we pick up a lot of times. A lot of patients. I mean, how many times do our team of APRNs, PAs, and myself, we find people have anemia, medication effects, sleep apnea. A lot of people do not think that women have sleep apnea.
Hmm. Yeah, those are good mimics. I think, you know, um, often also another thing I always think is if they've never had a cardiac workup,
Yes.
I often make sure that they get some sort of a cardiac workup as well, EKG, echo to start at least, just to make sure that we're not missing something structurally. I mean,
Oh,
is it that common of a thing in our patient population? No, but we have to dot our I's and cross our T's, right? I mean, we don't want to treat something and then come to find out we missed a diagnosis that would have been otherwise easily reversible.
well, I agree with you. I mean, Kate, that's why a lot of times you and I do the same thing. We'll take an EKG on somebody, and you might find something, or like a flattened ST wave or an EKG, and it's like, hey, this could be something. And I think again, it ties into a bias.
Yeah,
Cardiac conditions are common in the United States. Women do get cardiac conditions. And that's why I think we do the history, going with family history. What anything in family history. Many people even still don't know their complete family history for various reasons. A lot of family people don't know their family origin. People don't family histories. People, a lot of family don't go to doctors. People don't share things. Many of those things are very
yeah,
important. So I always think simple blood tests, EKG. Just those are really good starts. You'll find things that people think they have that we don't find as a
yeah.
counterbalance is like we do. I've not found multiple sclerosis. It comes up on Google search, fatigue, dizziness, lightheadedness, dizziness. And I would say in the last 20 some years, I can't remember the last time someone who came for a POTS evaluation, it was multiple sclerosis, or where MRI of the brain led to this. But it's more these other systemic issues
Mhm.
of sleep apnea or
Yes,
occasional EKG showing something, or eventually that echoed from that, or someone had inappropriate tachycardia and really thought it was POTS, or thyroid issue, or a nutritional issue that was
yes.
undiagnosed. It's more those things.
Yeah, and also I think when you also think of other mimics, physical deconditioning
Yes.
can be a big mimic. Not only physical deconditioning, but significant dehydration. I mean, how many patients do we see that have GI dysregulation,
Yes.
and end up end up, just being severely dehydrated, and you can still get abnormal tests from that because an individual can't hydrate appropriately. So I think that, that's always something that we have to take into consideration when, working a patient up. Is the history matters. and,
Yes.
and and also, the other aspect of it is, Rob, when you think about, you confirm a diagnosis, what's going on in your mind? Everyone always, I've seen pictures. People think of you as a magician. Um,
Woo!
yeah, the magician.
The rabbit.
But what's going on in your mind? Like, when you find this diagnosis, I know you really find taking the history to be one of the most important parts of
Yeah.
your visit. What are some differentials, if you will? You confirm POTS. What are you
Yes.
thinking about as a potential, why does this person have POTS? And what would you say the percentages of individuals that we never find the cause?
I think it's at least 25, 30% of people who might not find a cause. And I know this podcast, we're going to end it in a few moments. We're going to do another episode on this causes of POTS.
Yeah.
A lot of patients, we might not know the cause. And over time, you might find it out. With that said, one of the episodes, we're going to do treatments. It means
Yep.
even if you don't know the cause, you can still do treatments, the daily self-care, medications, and that path. Sometimes it doesn't always show. Like COVID, it makes sense. I was fine. I got COVID. I got POTS. It's very timeline, very sensitive. Sometimes it doesn't reveal itself right away. I think a lot of times when I'm with a patient the first time, especially the patients come from a distance national, I always call it, I'm just taking it all in. I'm just experiencing it, just all the variables, because if you order too much tests, sometimes the patients, it pollutes the water. Get the tilt table, take in the history, the timeline, what they've been through, what they experience, what
Mhm.
their story is. Sometimes the excessive testing tells you what's been done, but pollutes the waters as opposed to what's a day of your life been like? Where did that day, that thing change, right?
Yeah. And I think, for me, you're right. It's confirming what are we actually dealing with first and foremost. And we often follow these patients for a period of time, and we try to, figure out that etiology down the road. And like you said, in neurology, sometimes symptoms start before
Yes.
before we can actually identify that exact cause. And I mean, so following people long term can provide some benefit to make sure that we're not seeing any new developments, and making sure that they have people watching them. I think it's important, and I know we're going to really deep dive into that in an upcoming podcast episode. But I think this is a good start to kind of dig into the, what are you looking for in POTS? Why do we do the tests that we do?
That's a great point. I think it's a great end point. We discussed POTS, and maybe the next episode we're going to do is causes of POTS and what it means. So, Kyle, you are a great guy, great colleague, great friend. We finally start this podcast after all these years of discussion. So, episode 2 will come. Thanks for everybody who's willing to listen to us today and give us a chance. And don't
Yes.
and don't give up.
Yeah, do not give up. There's always help out there. We've seen so many people be successful with this diagnosis, and go on to live a very functional, high quality life.
Yes.
And I know there's times where you're going to get down and you're going to feel as if there's no hope. But like Rob said, don't give up. There is a lot of hope out there. So keep pushing forward. Make sure you find somebody that will be that advocate for you. And we look forward to kind of continuing to give you education and some helpful tips to make it through your everyday lives.
All right. We'll see you soon.
Take care.
Bye-bye. Autonomic dudes out.
That's right.
All right. Bye-bye.